I'm Alice Huffman, the California president of the NAACP. I'm here today in my business role. I own a consulting firm called AC Affairs. And I just give you like 2 minutes as to how these events come about, how you get to come to Luxury, how you get to hear one of the most renowned people in the cardiology field, who is also now the president of the National Medical Association. How does all this get to be? Well, about 10 years ago, Pharma, Big Pharma, that everybody loves to hate, had an initiative and called on Willie Brown and myself to help defeat the initiative, and we did. But we told them, don't come back to California if you don't invest in our community. I mean, don't come back next time thinking that we're going to run around and tell everybody to vote no because you want them to vote no, because my community don't like you and they need to know you, so that next time maybe they'll be a little softer and the job will be a little easier. So they have actually funded us in the beginning. When the heat was on, I did about 5 of these a year. Now I do 2 a year. But that's plenty for me because I still make the same consulting fee. I'm real clear. I'm real clear on my objectives here. And so we get to allow our local units, if they want to, participate as co-sponsors in a health event. There is no agenda here. I do have an agenda item, but it's not related to this, that I'll get to later. But in this forum that we do, there's no agenda. You simply come, learn something, talk about something, and we hope most of you who come really probably know a lot of this, but we hope you take it back to the community, and quality of health is as important in our community as money. And so, as we can spread the word on how to do a lot of prevention and how to keep ourselves healthy, then this event has accomplished its mission. I've been down to San Bernardino, I've been to Stockton, I've been to Los Angeles, I've been to Compton, I've been to San Diego. I've been all over doing these events, and they always are well attended, which makes me happy. But I can't put them on without a partner. Where's Leroy? Where's my partner?
It's outside.
So I called Leroy and asked Leroy, my president, and see, he's a new president, so he really worked hard. I called some of my old presidents that don't work like Leroy. But I called Leroy, and Leroy was, his aim was to please. I said, Leroy, find us a good place and let's have a CPAT lunch. And because of his great work, we are here, the chancellor's here, we're on campus here, we got food coming. 2 servers? Oh my. And so as soon as, this is what we're gonna do. As soon as Leroy does a welcome, and now somebody shook my hand outside that was a clergy member. As soon as he does the invocation, we'll try to kick this off. Then we'll come back and get welcomes from our co-hosts because we need to get the food started so that we don't, my guest speaker is from Los Angeles and he has to leave here at 2:30. So we can't be too late with what we're doing today. So my most brilliant president, Fresno branch of the NAACP, I know he's a local union member, but I'm not going to be talking about SEIU 1000 up in here. I'm just going to talk about NAACP. Come on, bring us a welcome, President Chandler.
Ladies and gentlemen, on behalf of the NAACP, California White, and on behalf of Fresno, Madera, and the Valley, of course, Hanford, I would like to welcome each of you to today's CPAP luncheon. I want to thank all of you for taking the time out and coming to spend some time with us, and let's all break a little bread and have a little fun and enjoy your evening. Thank you very much.
Amen. Thank you, Ms. Huffman, and to our distinguished guest, Dr. Williams. And I'm just going to have my really brief remarks right now so I don't have to come back and welcome folks. So I'm glad to be here. Thank you for the honor of having me on program. That was a surprise. But on behalf of all the clergy in Fresno, whether they like it or not, you are welcome on this afternoon. And if they don't like it, they can call me. Somebody say amen. Amen. All right. God bless you. This really is a great room, a group of, I'm looking at these faces, and this is a group of people that you want to work with and want to be around. The people sitting around you are powerful people in their own right. So really appreciate this time that you have with one another, because these are great people sitting around you. So let's go to the Lord in prayer. God, we are grateful for this time together. We are grateful, Lord, for your power and for your influence in our lives. And so we thank you now for this time together. We thank you, God, for this food that we're about to receive, for the nourishment of our bodies. And we thank you, God, also for the conversations and the dialogue that we'll have that will nourish our minds and our souls. In the name of Jesus the Christ, we pray. Amen.
Amen.
We're in his house. We have a surprise guest. He didn't know whether he was staying or not, but the chancellor's here. So we're going to let the chancellor give us a welcome and tell us how easy it was to get us on this campus and how glad he'll be if we come again.
Indeed.
Did I tell you that I named my youngest son Richard in honor of my guest? Okay. Well, I've already met some new friends and renewed some old acquaintances. So, and I know Dottie's here to make sure I don't say anything wrong. And she takes care of her brother as well, if I understand right. So, anyway, thank you for letting me say a few words. Welcome to everyone. It's a real pleasure to have you here in this beautiful building in this college. We're getting ready to start. Monday, students will be back. Thursday, our faculty and staff will all be back, and we'll be welcoming them all right here. And so you get to be the first ones to go through the line. Thanks to our culinary arts people for coming out here, and they did have to do some hustling, and they did. And so I'm glad that we got things ready for you. Anyway, welcome to State Center Community College District, especially the Fresno City College. And then if you ever get a chance, go down and see the newest college. This is the oldest college in the state of California, oldest community college. It started in 1910, and it was the first community college. And we serve about 50,000 students right now. And most of them are right here. We'll have about 30,000 students that will start up here this next week. And then we have Ridley, which was started in 1924, and that's a great college. And then we have the newest college in the state of California, which is Clovis. And then we've got centers up in Madera and Oakhurst, so we cover a geographical area the size of Connecticut. So we're pretty proud of that. My good friend Tate Hill is here, and he's a TV star, so I was telling him I think lots of it. Anyway, I don't have any other comments except thank you for letting me take the microphone, and it's good to see all.
Are you gentlemen prepared to serve the tables? Okay, so while they're putting the food out, we're going to ask my co-hosts to come up and bring greetings. Representing the Black Americans. Hank is representing the Black American Political Association of California, better known as BAPAC, Fresno BAPAC. He's also on the state BAPAC. He's been in BAPAC for about 90 years.
We just want to take a moment to welcome all of you to Fresno. They're out of town, and for our home folks, we're glad to see you come out. And I've had the pleasure of working with this young lady over a period of time. And for years, we've tried to make changes here in California and a lot of things. Very successful in many ways, and keep up the good work, and glad you are here to support us.
I'm Rita Williams. I am Secretary of African American Faculty and Staff here at Fresno City College. We're co-sponsoring, helping out NAACP. We will be having a welcome back event at the end of the month, so look for your emails, your invites. It would be great to see you guys. Love talking to the community and helping out and partnering.
Thank you. Half of y'all in the room know Desi, but Desi is a friend. 40, I won't say how long. Well, I tell you, long enough for Robert to be my godchild. That's how long. Before he was born, we were doing Bawapa and things together. I'm only 25. So it's always a pleasure to go into the area where Des is located. And when Pam came, she said, well, you know, I saw you, Dr. Williams and Desi, the three amigos, so I know how you're going to be together, Desi. Thank you, City.
Well, good afternoon, everybody. It's too quiet in this room. Is everybody alive and well and breathing? And let's say amen or something, Wall. Good afternoon. Well, it's good to see everybody, and once again, I want to thank my dear, dear sister friend, Alice, and we really are like sisters indeed, and our families have been close for many, many years, and I want you to know that when she talks to you, like what you see if you don't know her, is what you get. She means every word that she says. I am really pleased that we have had the opportunity in terms of BWAPA, Black Women Organized for Political Action, to, as long as Alice and CPAC has been doing these events, we have been able to co-host them throughout the state of California, and I'm glad that we are in Fresno this day. On behalf of our local chapter and our local members, our very young and talented President, Shirley Nicholson, just got back from South Africa and could not be here today, but I wanted to extend on the organization's behalf, and I want all the BWAPA members just to say a shout out. Hey, because I know you're all in here. Hello, up there, raise their hand, there they are. Thank you so much for joining us, and we look forward to getting some additional wonderful information about health disparities today. So thank you so much for joining us.
All right, I'm gonna tell y'all, the next voice you hear will be Dr. Williams after I do this little cheating. You have something in your packet that was supposed to be a handout on the table, and it's called No on Prop 61. And I told you there's no agenda here, so there is one agenda. We have a form that we'd like you to fill out that's on the other side of your packet to say that you have been here. You know, I do have to report to somebody. And if you sign that form, that means my money will keep coming so I can do this somewhere else. Yes, so I want you to sign, yes, the CPAP form. Also, I want you to take a critical look at No on 61. And if you as an individual or you as an organization can take a no side, I'd like to take a few forms back with me. This is a very deceitful proposition. It purports to reduce the cost of medicine, but when you look at how it operates, if you look at this, this one sheet, you see how contradictory it is. And if you look at another sheet, you'll see where many of our organizations have already opposed this, signed up on the no side. And so if I could take some notes back, organization or individuals today, that would be a big help for our campaign, because we're really worried about getting the word out, and we're hoping to do that. So I'll come back to those later, because I want to make sure that Dr. Williams has time to do his presentation. And as I told you, he is renowned. He is now a big shot. Don't ever try to read his books, because they're volumes. Everything you ever want to know about your health is in his volume, especially if you're African American and if you have a heart. He gets all kinds of awards. He has always become NAACP's private doctor, because he does every Friday of APAC, of NAACP, I don't know about longer. Every Friday of NAACP state convention, we do a health breakfast, and he either makes a presentation or moderates it. And so he's a part of the family. Also, he's a man that kind of moves around the communities and knows what's going on, because he's a jazz musician. And so when he works on Thursday night of the convention, we hear his music, and he puts a musical package together for our state convention every year, whether we're north or south. So he's multi-talented, and they always said that if you give your child music, maybe they can grow up to be a doctor or somebody, because they can count. And I guess that's really what worked with him, because he can count. So ladies and gentlemen, the man who knows most about African American health issues, health disparities, and who is now, I can say, the president of the National Medical Association, Dr. Alan Williams.
Thanks to my good friend Alice Huffman. I think we ought to have a round of applause for her for all she does. And I want to repeat my name for you. It's Richard Allen Williams. And those of you who either are AME or know AME, know about AME, know that my namesake, Bishop Reverend Richard Allen, who founded the AME Church, back in the 18th century, was a fantastic ex-slave who has done a lot more than I have, and is much more renowned than I am. But be that as it may, I'm here to speak to you about something that is not exactly what is in your program. I'm going to give you an update on the status of healthcare disparities and healthcare reform. Before I do that, let me say that it was a pleasure to meet the Chancellor and to have a brief discussion with him, especially about his son, Richard, not named after me, but
Close
his
enough.
name. Appreciate it. And you mentioned the history of the, how historical the community college system is in California, and that this is the oldest, I believe you mentioned, right here. And I believe that goes back to the 19th century, is that correct?
1910.
1910, 20th century, early 20th century. And I'd like just to mention that my alma mater is a school that started in 1636. Not competing with you or anything, but just putting things in perspective. It's called Harvard University. And it started, however, after the beginning of slavery in this country. And even though I'm proud of being a graduate of Harvard, I'm not proud of the fact that in its tradition, some of the masters and presidents of Harvard were slave holders, slave masters. And that was just recently revealed. Some of the houses that I lived in and so on and so forth were actually built by slaves. So, you know, it's interesting when you take a deeper look into these things. But here in California, in the community college system, we have a pristine system, which didn't have all of that stuff involved in it. And I just congratulate you on being the leader of this wonderful system, which I don't know how many people know very much about it, but it is absolutely amazing. He needs to be given all the praise for running such a large system which does so much for our kids. So I want to give him a round of applause. Well, let me get started on what I'm here to talk to you about, and I'm going to try to do it as expeditiously as possible. I mentioned that I'm going to give you an update on the status of healthcare disparities in healthcare reform, and you see some of my credentials up there behind me. Mostly those. I was just elected president of the National Medical Association, which has 50,000 adherents and is the largest black medical organization in the world. I'm really proud of having the opportunity to lead this group, because there are many things that we need to do for African Americans in this country which are not being done either by our government or by private settings or whatever. So I want to do whatever I can, and I only have a year during my presidency to do that. I'm not going to try to describe to you what some of these programs are, but they do have to do with healthcare disparities, eliminating them, and also refining healthcare reform. So in this talk, you'll see as we go through that there are 110 slides listed. I'm not going to impose that on you. So when you see that, relax, that's not going to happen. But I am going to show you 10 or 12 slides that I think will be important if I learn how to operate this thing correctly. Now, can you see that well? I'll read it to you. I want to give you a brief history of what's called the ACA, or the Accountable Care Organization, or Accountable Care Act. before I do that, let me mention that the ACA, or what is now called Obamacare, was initiated on exactly March the 23rd, 2010, when it was signed into law by President Barack Obama. And I think that it's important for all of us to understand the importance of this. And it was the first piece of legislation on health reform that was passed in 100 years. The earliest attempt was made by President Theodore Roosevelt. This bill was defeated in 1910. Exactly 100 years later, Barack Obama's bill passed. There were other bills in between. In fact, during President Clinton's reign in the 1990s, Hillary Clinton at that time tried to get a bill passed, and it was defeated. The ACA was narrowly passed by Congress after an intense debate lasting for years, actually starting in 2008, and eventually winding up with passage. Now, Medicare and Medicaid, which you're familiar with, were passed in 1965. I might add that the American Medical Association at that time opposed those bills. The National Medical Association, of which I'm president now, was strongly in favor of these acts, these bills, and these programs, which now have been touted up to the time of the healthcare of the ACA as the most successful attempts to reform healthcare. And we all know about Medicare. Many of us in this room utilize Medicare, and some of us utilize Medicaid, or in California, Medi-Cal. So the ACA has survived more than 70 attempts by Republicans to repeal it, and several attempts in the Supreme Court to declare it unconstitutional. And that's pure partisan politics, no question about it. There are people who do not want to see Obamacare, as it is called, and which he's accepted, to succeed. If it doesn't succeed, you don't succeed. It's as simple as that. If you allow this gift to the American people, and particularly to minorities, to be pulled off the table, you are going to suffer. There is no question about it. Everybody in this room is going to suffer from that being done. However, we have to recognize that this is a work that's in progress. Since it was initiated in 2010, several features of it have gone into effect. One of the earliest features was to allow kids who were up to the age of 26 to stay on their parents' insurance policies. And that was a big deal, because many of those kids would not have had insurance coverage had it not been for Obamacare. That started in 2010. There are other things that are still in progress. For instance, you've heard about the donut hole that has to do with Medicare Part D, and how it's closing will benefit you. It takes a while for it to close completely for everybody. Complete closure is expected by 2020. That means that by 2020, you won't have to worry about paying these co-pays and so forth in regards to your drug benefits. So you can see how things are evolving over time. And what I hope to tell you in brief is what the benefits are of the program, and also what some of the drawbacks are, because there are certainly some things that are being cited in regards to both of those aspects. Before I go further, I would be remiss if I didn't put in a brief commercial here for something that I was responsible for. This is my eighth book, which is called Healthcare Disparities at the Crossroads with Healthcare Reform. And this was published in 2011. It lays out in great detail many aspects of both of those things, both healthcare disparities and how the ACA, the Affordable Care Act, has been able to impact on healthcare disparities, causing reduction, in some cases elimination. So the next thing that I'm going to do is to show you a little bit, just give you a little taste of something that Pam Fobbs, my good friend here, along with her husband, Dr. Denard Fobbs, have asked me to elaborate on, and that is how the ACA actually impacts, or has impacted, healthcare disparities. We all know that healthcare disparities could be described as the differences that occur in the way that health care is delivered to different people, different populations in the United States. We know that there is not equity in healthcare delivery. Some people get more than others. And this is something, these things that we call healthcare disparities, that reach way back to slavery. In fact, we talk about what is called the healthcare, the slavery health deficit. And it is really based on the fact that slaves did not receive good treatment, obviously because of the fact that they weren't the favored people on the plantation. And they were made to work hard without getting good medical care. In fact, I could tell you some stories about some conspiratorial things that occurred, such as the fact that slave owners, or slave masters, slave holders, obviously looked at slaves as being commodities. They were property, and valuable property at that. If you didn't have healthy slaves, and you couldn't get your work done, and you weren't going to make any money. Cotton or corn or tobacco or whatever being harvested. And so even though they didn't give top priority to slave health, they did want their slaves to be insured against illness. Guess what? There are some companies that came forth and provided the slave masters health insurance on slaves and life insurance. So that if a slave died or got sick, the slave master didn't lose anything. He gained because he was going to be paid by the insurance company. Isn't that something? Guess who some of those insurance companies are? I'll name just two of them, and I can back it up. So I'm not telling you anything that is not true. One was Prudential, and another one was Aetna. You recognize those names, don't you? Okay. So you can imagine how concerned we should be, and I am, in regards to learning things like this, and learning the fact that back in the 18th century, there was a gentleman named Hoffman who was a demographer and a statistician. And he looked at the slave population of the United States, did a survey, in fact, and he worked for Prudential. He determined that based on the poor health status of the slaves, he could predict the extinction of the black race by the year 2000. Amazing? True. Now, obviously, the black race has not become extinct, but you have to bear in mind that he was talking about not total demise, but about the fact that there was so much sickness that was occurring that our race was going to be decimated, and we were going to lose a lot of people to what were not known at that time as healthcare disparities, but to differences in health delivery, healthcare delivery. So that gives you a little bit of background in regards to what this is all about and how important it is. And it lasts and exists right up to the present time. It doesn't have to do just with African Americans, but with other minorities, what we call underserved minorities in this country. And we all have to work together to defeat and eliminate healthcare disparities. I plan to show you a few slides that indicate some of the aspects of healthcare disparities. Can't show you very much, but the next slide is just not too long ago, in 1950. This is a slide which you can't see very well, but I'll describe it to you. It's called, this is in Charleston, South Carolina, and this is Old Roper Hospital, as it was called. I don't know how many people are from South Carolina or around that area, but like I said, 1950 wasn't that long ago, right? 60-some years. And if you looked closely, you'd see that all of the patients in the beds are black. All of the doctors and nurses and healthcare professionals servicing them are white. Why is that the case? It's because there was strict segregation and discrimination in hospitals, especially in the South, prior to 1954 or so. I can't go into details about how it was overturned, but suffice it to say that if you were a black doctor practicing in, say, Charleston, South Carolina, and you had a patient who needed an operation for appendicitis or gallbladder disease, or just treatment of any disease, and that patient had to be admitted to the hospital, had to be admitted under a white doctor and cared for by the white doctor. So the black doctor lost his patient and lost the income that would be associated with treating that patient. And so that's what you're seeing on this slide. It's an aspect of healthcare disparities, of strict discrimination, which eventually was overturned. Not by actions of the American Medical Association, the AMA, which we do have a good relationship with now, since they apologized to 8 or 10 years ago. But due to the action of black doctors ourselves. And Denard, you know all about this. You know what efforts have been made through the NMA to make sure that justice is served in regards to not only our patients, but to our doctors. So that's one example. I'll show you maybe a couple more. This is the back of Freedman's Hospital. Did it come up? No, there it is. This is Freedman's Hospital, which was the first land-grant hospital in the United States, established in 1868. It was the principal hospital for Howard University School of Medicine, which was the first black medical school established in the United States in that same year. Freedman's Hospital is a legend. It's legendary because of the fact that up to the time that it was started, there were no hospitals that existed for the treatment of blacks. And this was especially difficult during what we call Reconstruction, that is a period of time after the end of slavery, and the end of the Civil War in 1865. And it was important also because of the fact that for the first time, blacks had their own hospitals to treat their own patients. And it worked out extremely well. This hospital still stands in Washington, but has largely been replaced by the newer Howard University Hospital. But I mention that because of the fact that it played a role in trying to eliminate and dispel their healthcare disparities. I can't show you too much more in regards to this, but I do want to show you, oops, one more slide. This is a slide of a young slave lady who is kneeling on a table in a tent in some southern city. And she is being observed by a gentleman called Dr. J. Marion Sims. Denard, this is a gentleman, as you know, who practiced in your field and was called the father of American gynecology. And you're shaking your head in sorrow in recognition about who he was, because what he is about to do to this young slave lady is just absolutely deplorable. He laid her out on the table, naked, before the world, and progressed to doing examination of various parts of her privates in full view of white populace surrounding. So he was an exploiter, as it says here, of slave women. But he built his reputation on the experiments that he did on slave women. And ladies and gentlemen, this is one of the reasons that a lot of black folks are very wary of entering into clinical trials and things of that sort, because they don't feel they want to be experimented on. They know about things like this, these things. It's not just Tuskegee. We all know about Tuskegee, the syphilis experiments. But things like this are terrible. And yet Dr. J. Marion Sims went on to great fame, as I said, being called the father of American gynecology, and having a statue actually erected to him in Central Park in New York City. And so if you're ever in Central Park in New York City, I invite you to go up and they can do what I did. That is to expectorate on that statue. So, a lot more that I could show you, and a whole history, and in fact, the entire book that I have written called The Textbook of Black-Related Diseases that is devoted to things like this, to make sure that folks recognize how we have been exploited over the years and how we ain't gonna take it anymore. And I'm gonna be especially aggressive in regards to this during my presidency of the National Medical Association. So, let's move on now. I'm going to zip past a lot of slides, so if you'll bear with me for a minute. I'm going to try to get to here's one that I need to show you. This is a slide of President Clinton and Vice President Gore, who are shown during a news conference in 1994. They are apologizing to Mr. Shaw, who was 94 at the time. He was a survivor of the Tuskegee syphilis experiments, which occurred in Tuskegee, Alabama. I can't give you all the details about it. If you don't know about it, you need to read about it, because it's a part of the dark side of American medical history. But President Clinton, and I give him credit for it, did apologize on behalf of the American public to Mr. Shaw and to all of the syphilis victims. Okay, now let me go to what I'm going to tell you today about the here's something that is kind of a cartoon. And here's a black lady who's saying to the doctor, it's a white doctor, "Doctor, studies show that if I were a white male, you'd be rushing me to a cardiac catheterization procedure." That's something that I do in my field, putting the catheter inside the body and up into the heart to diagnose heart disease and so forth. And the doctor says, "No kidding, I thought a Rolaids would do the trick for you." What he's referring to is exactly what has happened historically in this country regarding black people and the way that we've been treated for things like chest pain. Go to the hospital, to the emergency room, see the doctor. "Doctor, I have pain in my chest. Am I having a heart attack?" Doctor looks at the patient, based on what he's been taught in his medical training, namely that black people don't usually have heart attacks. That was actually predicted 25 years ago when I was going through my medical training. Kid you not. And so the doctor uses his best judgment that he's been trained to develop. Says, "Oh, well, this can't be a heart attack. This has got to be an upset stomach, gas, what we currently call GERD, gastroesophageal reflux disease, or something like that. Can't be a heart attack." So he tells the patient, justifiably, according to what he's been taught, that the patient should go home and take a Rolaids or some kind of medication to oppose the gastric acid buildup. And patients often did that. The only thing is that they went home and died. And And so it's not amazing, I guess, to understand why the statistics back then didn't show a large number of black people in the hospital and medical system suffering from heart attacks, because they died at home from their heart attacks. They never got really a chance to get into the system, and that's a fact. Now, I started an organization 43 years ago called the Association of Black Cardiologists. And the reason I started it was because through my training, I had observed exactly what I just told you about. That black people were looked at as a different kind of people. That we didn't have the same diseases that other people did. And I documented that that was true in my textbook of Black-related diseases. The only thing is that back then, people were saying that we had diseases which showed that we had inferior physiology, that our hearts were different. I could tell you so many stories about that, but it was derogatory the way it was being told to us at that time. What I tried to do was just to clarify things with my book and also with the development of this organization. So the ABC, as we currently call it, is the best small medical organization in the country. It's your organization for heart disease. We have 800 cardiologists in the organization. Virtually every black cardiologist in the country is a member. It's nationwide. Headquarters in New York. We have a $12 million building, headquarters building in Atlanta, Georgia. So we've done pretty well. The main thing is that we reversed the trend of thinking that heart disease in blacks is not an important matter. We know all about high blood pressure and hypertension. We know that black people have strokes, and I often say that because we have what we call hemorrhagic strokes due to high blood pressure more commonly than whites do, who have ischemic strokes due to blockage in the vessels, that there are different strokes for different folks. It's really true. I'll tell you today about the hearts were different. I could tell you so many stories about that, but it was derogatory the way it was being told to us at that time. What I tried to do was just to clarify things with my book and also with the development of this organization. So the ABC, as we currently call it, is the best small medical organization in the country. It's your organization for heart disease. We have 800 cardiologists in the organization. Virtually every black cardiologist in the country is a member. It's nationwide, headquarters in New York. We have a $12 million building, headquarters building in Atlanta, Georgia. So we've done pretty well. The main thing is that we've reversed the trend of thinking that heart disease in blacks is not an important matter. We know all about high blood pressure and hypertension. We know that black people have strokes, and I often say that because we have what we call hemorrhagic strokes due to high blood pressure more commonly than whites do, who have ischemic strokes due to blockage in the vessels, that there are different strokes for different folks. It's really true. So we have to keep in mind that there are differences, but what the differences are based on. And if anything, we should think that black people have been extremely successful in being able to survive the rigors of all these years of slavery and the aftermath of slavery and so forth, and still be as strong as we are. So it's sort of a survival of the fittest going through in the struggle for existence and persistence. All right, well, let's move on real fast. President John Kennedy was one of my favorite people in history. And just to get to the end of the part regarding healthcare disparities and differences that are being made or have been made between people and all of the things that are professed about inferiority and superiority. He said, if we cannot end our differences, at least we can make the world safe for diversity. For in the final analysis, our most basic link is that we all inhabit this small planet. We all breathe the same air, we all cherish our children's future, and we are all immortal. Isn't that a fantastic statement? So, okay, moving on. Now, I told you about a little bit about the ACA before I started talking about healthcare disparities, and now I'm going to end with the ACA with a brief discussion about how important it is. I gave you kind of an overview, now I'm going to give you some details. I told you that it was started on March 23rd, 2010, when President Barack Obama signed the Affordable Care Act. It's actually called the Patient Protection and Affordable Care Act, PPACA, into law. And I told you about how historic an act this was and is. Here's the purpose of the ACA. There are three main ingredients, and it's like a three-legged stool without all of these legs being there to balance the stool, it will fall. So the first leg is to provide greater access to health care for the American people. What could be more direct and simple in explaining the importance of the ACA? People have to have access to health care. If you've got doctors and you've got hospitals on this side, and you've got patients who have a need for medical care on that side, the patients have got to get to the doctors in the hospital. What's blocking their path? The fact that, especially poor people, there is not money that is available for them to access the system. That is, to see the doctors and pay the doctors' bills, to go to the hospitals and pay those bills. What makes it possible, or would make it possible? If they don't have cash money, they have to have health insurance. Now, I mentioned to you that in 1965, Medicare and Medicaid were passed. Those bills helped mightily, because up to that time, people didn't have anywhere to go. They didn't have any resources or support. Now they do, but that has not been enough. Medicare is for older people. Medicaid has been for people who need a safety net to pick them up. And it's done a good job in that regard, but up to the present time, current years, recent years, it hasn't been broad enough. Recently it's been expanded. But there was a great need that President Obama saw in the provision of health insurance coverage to people in need. And so that was one of the principal purposes of his creating the ACA. The second need, or the second purpose, was to lower the costs of medical care. Costs of medical care are astronomical in this country. We rank number one on the list of costs for medical care. Our medical care budget, so to speak, is $3.5 trillion, far more than any other country on earth. And if the healthcare budget for the United States were looked at as a separate economy, it would be the 5th or 6th largest economy in the world, which is absolutely phenomenal. And yet, for all of that, we rank 35th on the list of developed nations in regards to delivering excellent medical care. And Denard, as you know, those measures are mainly made in terms of maternal mortality and infant mortality. We have the highest and worst figures in the world for those particular aspects of health care. And so we don't do very well with all that money that we spend. And that was one of the incentives for President Obama to create this act. The third one is to increase the quality of health care, not necessarily the quantity. We have plenty of quantity to go around. Got a lot of doctors and a lot of hospitals, more than any other nation on earth. But we don't get a lot of bang for our buck, so to speak, from the standpoint of the quality. And when I say quality, I mean, are people able to go to the doctor, to the hospital, and come out with a great outcome? Do they do well after their treatment? If Ms. Jones goes to the doctor for a gallbladder problem, does Ms. Jones come out feeling better, being rid of that problem, or does Ms. Jones not come out of that treatment at all? And as you know, you all know, things happen, bad things can happen, and do happen. So there was an incentive based on statistics to try to increase the quality, to keep people from having to go back to hospitals after they've been treated, or back to the doctor, to form some type of system that would focus on not crisis health care, but on preventive medicine, keeping people from getting sick in the first place, and making sure that we focused on wellness, not disease, but on wellness. How important a concept is that? And so those are some of the purposes. Now let's see what the main benefits have been of the ACA through this year. I'm going to read these to you. It's kind of detailed, but I'm going to do it fast. First of all, looking at those things that I outlined to you just now. First was the issue of access, right? Can people get to the doctors and to the hospitals? They have to have insurance to do that. So increased access to treatment. Has there been evidence of that? Absolutely. The uninsured rate declined by 43%, might as well say 50%, from 16.0 in 2010 to 9.1 in 2015. What a drop. Never been a drop like that in the history of healthcare delivery in the United States. And I think that bears repeating. This has never occurred before, and the reason it occurred is because of Obamacare. That means that lives were saved because people now are able to be insured. And as of 2015, 20 million more Americans were insured. Up to that time, for those of people who were uninsured, up to that time, the number of Americans insured or uninsured were much higher. There were about 50 million people underinsured. Cost containment. Remember I mentioned that cost was a second leg on that stool, and that we wanted to try to contain costs with this new bill. Some people said you couldn't do all three things at the same time and be successful. You couldn't increase access, you couldn't contain costs, or as we say, bend the cost curve, and you could not increase quality. That something would have to suffer. Well, let's see if costs did suffer. What we found was that there was a reduction in personal debt, that is the amount of money that people had to spend out of pocket, and especially for people who were seeking Medicaid or Medi-Cal, and it provided them with greater financial security. A lot of details that I could give you on that. Suffice it to say that that happened. There was a mean annual growth in real per enrollee Medicare spending. What that means is that the amount of money that had to be spent on each Medicare recipient was reduced. The spending has been negative through 2014. Never happened in the history of Medicare since it was put into effect in 1965. And so it's now projected to spend 20% for $160 billion less in 2019 alone, in 1 year, Bernard. 1 year, it's going to save that much money. And that was predicted not by President Obama or by the White House, but by the impartial Congressional Budget Office, the CBO. Those are the folks who look over all the figures and give you an impartial view of what's going on with your money. Let's go to quality. That was the third leg on that stool. Quality of care improvements. The Agency for Healthcare Research and Quality estimates that the decline in hospital-acquired conditions has prevented 84,000 deaths over a 4-year period, over the last 4 years. The 30-day readmission rate decreased from 19 to about 18% in 2015. That's a big decrease. That means people going back to the hospital after they've been admitted, say for heart failure, which is the biggest readmission entity, in a 30-day period. And the Department of Health and Human Services estimated that there were 565,000 fewer readmissions in the 5-year period 2010 to 2015. That's a lot of people who didn't have to go back to the hospital. That's a lot of money saved in our medical economy. Now, one other benefit that is still emerging and needs to emerge more is a reform of the healthcare delivery system. That means the way that doctors and hospitals are paid and the way that billing is made. Fee-for-service is something that I can't describe exquisitely today, but I think a lot of you know what it has to do with it. It really has to do with a fee being paid to the medical provider for a service being rendered, whether that provider is a laboratory or a hospital or a doctor's office or whatever it may be. That's being changed now because that's based on an old-fashioned focus on volume. In other words, the more patients that are being seen, it was thought, the better the system must be because all these people out here are sick. And so that was the criterion. How many patients are you seeing and how much? And that was the basis of the money, not the money you're going to be making as a doctor. That is being switched over to a value-based system. In other words, how good an outcome do you have as a patient after you've been treated by that doctor? Are you well now? Or do you have to go back into the hospital within 30 days? Or do you still require a lot of residual treatment? You know, chronic medical care, chronic health care is the cost of most of that $3.5 trillion medical bill that we have every year. That's every year, folks. 70% of that bill is due to chronic diseases like diabetes, heart failure, hypertension, etc. So if we can get around those diseases in regards to treating them better, having better outcomes, and so forth, the better off all of us will be, and our economy will benefit from it, as well as all the patients. So we have to change and reform the healthcare delivery system. That is being done. There are creations of what we call vertically integrated systems like accountable care organizations, and there are medical homes which are being developed, which utilize, which use a coordinated approach to care, so that the patient doesn't have to go here for one thing and there for another thing, and so on and so forth. It costs money, it costs effort, and it's difficult for patients, obviously. What about having all of those things dispensed in one location? Have all the doctors in one location that can do all the things that patient needs? That's the kind of thing that's coming about. And how about rewarding doctors for excellent care? It's what we call excellent care, what we call pay for performance, or P for P as it's abbreviated. In other words, if you do well as a doctor in treating these patients, you're going to get paid well. If you don't, you're going to get penalized. That's the way the system is evolving now. Now, we have to be careful with that because a lot of these organizations do what we call cherry picking, and that's detrimental to the interests of, for instance, blacks. So let's say that we have a black neighborhood which has a lot of hypertension, and hypertension is a high-ticket item, high-priced item in regards to treatment. The organization, the Accountable Care Organization, or whatever it might be, that might be in that area, might kind of narrow its access to the patients from that community to that ACO. In other words, they may be denied entry, which is something that's supposed to be illegal under Obamacare, but actually Obamacare is not really, that is not controlling that very well. That's something that needs to be done better so that everybody will be treated equitably. Right now, even with Obamacare, that does not occur. So keep in mind, there are lots of deficiencies that still exist. Now, I was going to show you a lot of slides to continue, just demonstrating graphically the benefits, but I'm not going to show you a lot. I'm just going to show you a couple. Here's the one that has to do with the fact that, I don't know whether you can see this well enough, but it shows a graph of time from 1960 through 2015, and the uninsured population on the vertical axis. And what it demonstrates is that over time, there has been a tremendous drop in regards to the uninsured population. The big drop occurred somewhere around 1965 when Medicare and Medicaid came in. And then things stayed relatively stagnant over a period of years until 2014. That was the 4th year after Obamacare. And you see that sudden steep drop off at the end? That's the drop that I was talking about, that 43% reduction in the number of uninsured individuals. 20 million people added to the insured rolls. That's the dramatic slide that you want to take away from you in your memory, because that shows the most important aspect of, up to this point of Obamacare's effect or impact. Now there are some others that I'm not going to try to take the time to go into details on, but these slides that I am showing you, remarkably, are from an article which was published, and I've got a copy of the article here, was published last week, August the 2nd, 2016, in JAMA, which is a journal of the American Medical Association. Last week, today's the 9th, it was exactly a week ago that this came out. Guess who wrote the article? President Barack Obama. He's the first president who ever wrote an article in a medical journal like this. And he was extolling the virtues of his program, the ACA, and doing it very well. And so all of these slides that you see here, which I'm not going to give you details on, are from that article, which show the benefit of Obamacare in regards to things like the amount of money people are paying out of pocket and the number of people who are benefiting in general, the effect on Medicare, and also the fact that you see this flatness of these particular curves, which indicate people not paying much out of pocket for their medical care. And this final one has to do with the dramatic reduction in 30-day readmissions due to Obamacare. So you can see that there has been a lot of progress made. Now, I'm going to move to the chase, jump to the chase and tell you what the main deficiencies of healthcare reform are, and then open things up to comments and questions as I close. These are the main deficiencies. First of all, despite the fact that this is a wonderful, marvelous program historically, there's no question about the fact that insurance premiums are increasing. Here's a newspaper that I brought to show you. This is from the LA Times, Wednesday, July 20th of this year. And you can see it says, California Obama rates to jump. That means if you have insurance through Obamacare, your rates are going to go up. And they're going to go up dramatically next year, 2017. And there's no question about it. And I've given you the documentation on this slide. The last 2 years, in 2015 and this year, 2016, the rates rose, but they rose at a controllable rate, 4.2 in 2015 and 4.0% in 2016. And next year, as I've indicated, the rise is going to be 13.2%. Huge jump, more than 2.5 times what it is now. What's the reason for that? Well, one of the reasons is alleged to be the rising costs of medical care, such as drug costs. Drug costs are a problem, and yet I don't think you can lay all the blame at the feet of the drug companies, the pharmaceutical companies, in regards to this. It's something they have, there's some things there that need to be fixed. But by and large, bear in mind that the pharmaceutical companies have done a remarkable job in developing these fantastic drugs which are used to treat us in the first place. So anyway, the Blue Shield's rates are going up more than 19%. Anthem's rates are jumping 16%. I think, is it Health Net that's pulling out? One of the gigantic companies is pulling out altogether. Several of them are threatening to pull out of Obamacare and not be involved in the exchanges anymore at all. So there's going to be less competition. This will make insurance coverage less affordable for the public. That's a big concern that all of us need to have. We've got this marvelous program that's doing a great deal of good, but are we going to be priced out of the market? That's something that you need to keep your eye on. You need to talk to your Congress people about. You need to be very serious about this, because there's a possibility that that marvelous silver plan that you might have, you might need to ditch that or at least transfer to a bronze plan, which would give you a higher deductible, but would only be useful for catastrophic coverage. So those are the things that you need to consider. This is serious, folks. This is your life we're talking about. And so if there's anything that I can tell you in this little lecture today, is that keep your eye on the sparrow, so to speak. Make sure that you look closely at these insurance plans and at this coverage, and that you talk to the experts about what is best for your particular situation. And that you read the papers and read articles, but don't believe everything. Here's something that came to my attention just the last couple of days. I read a journal called Medical Economics, and it says at the very top, Obamacare fails. Now this is, excuse my expression, I don't know what your politics are, but this is a Republican journal. And it says it's always attacking Obamacare. But it has a lot of smart stuff in it that you need, that doctors need to pay attention to. And it has an exclusive. U.S. physicians tell us why they hate health care reform. Well, there's some hateful things in there for doctors. Patients don't necessarily have sympathy with those. But in any event, there is something for all of us to like, and maybe something for all of us to dislike. We have to really look at it very closely. So some people are feeling that they might not be able to afford health insurance. That's a premiums rise, especially as has been threatened if subsidies are removed. Because subsidies make it easier for you to pay for your health insurance. Now, Covered California is our brand of health exchange here in California. And Alice, I don't know where you are, but you know, right, Dr. Lee has been very aggressive in regards to making sure that Covered California is something that's spread throughout the state. And I agree with him. I've helped him spread that message. I think it's been grand. But all of what Covered California has done, and it's done a lot, to bring more health insurance coverage to Californians, has not been enough, because in the end analysis, it takes a brilliant amount of negotiation with the insurers in the first place, the people who provide the insurance. It used to be in the early days of Obamacare that the health insurance companies were cowering about Obamacare. Oh my gosh, they're going to suppress us too much. Now they're much bolder. They think that they can do things, and they are getting away with some things that they couldn't get away with before. And so it's going to take more intense negotiations from Peter Lee and others in Covered California through the exchanges to keep the prices in check. And right now, the law is kind of weakening in regards to the controls that can exert on these insurance companies. Bear in mind, the insurance companies are not going to lose. They will not lose. They've got a, what do you call it, a pat hand? They got a good hand anyway. In the end analysis, they're going to win and make money. They will not lose. So we have to have better negotiation. We've got to have more congressionally imposed controls on insurance companies. And we've got to be, as constituents, as the stakeholders, we have got to be the people who will go to our congressmen and demand the changes that need to be made. Only you can do it, and you have every reason to do it. So I'm going to end there. I could make a lot of suggestions otherwise from the standpoint of what needs to be done, but the best suggestion I can make is for you to keep your eyes open, for you to read, become aware if you're not already. If you are aware of what's happening with Obamacare, become even more aware, because it's a tricky thing. It's tricky because of what people are doing to try to defeat it, and it's also tricky in regards to the fact that the current administration is going out of business in November, and even though Hillary Clinton is probably going to come in, there's no guarantee that there's going to be a continuation of the progress that has been made. We must carry on. We must make sure that this remarkably historic program gets the kind of continued support that it needs, and only you can provide it. You, the people of California. You, the people who are interested. And you must carry this message to your friends and your associates. So I will end there and see if there are any questions or comments, if we have time for that, Alice. And thank you very much for inviting me all the way up here in Fresno. Yes, ma'am.
I had a comment in terms of advocating for patients and helping to lower costs. Said we need focus groups in the community, not what happened to the insurance company or that system, to teach people how to read, what services were done for them, like your explanation of benefits. People need to have a clear understanding of their hospital bills, and you will see, and you'll call the billing department, well, we don't do that, we just use codes. You have to tell them that's the law. They have billed you for a million things they need to get.
You're absolutely right.
All kinds of kids and slippers, paper slippers and all that, that's one issue, but the other thing is
But
that.
before you go on to the next one, let me just take up that issue. That's something that is dreadfully lacking. It is in the 3,500 pages of the bill here in Fresno. Yes, ma'am.
I had a comment in terms of advocating for patients and helping to lower costs. Citizens, we need focus groups in the communities. It's not going to happen to the insurance companies and medical system. To teach people how to read what services were done for them, like your explanation of benefits. People need to have a clear understanding of their hospital bills. And you will see, and you could call the billing department that, well, we don't do that, we just use codes. You have to tell them that's the law. And they have billed you for a million things that you didn't get.
You're
The cost,
absolutely right.
all kinds of kids and slippers, paper slippers and all that, that's one issue. But the other thing is
But
that,
before you go on to the next one, let me just take up that issue. That's something that is dreadfully lacking. It is in the 3,500 pages of the bill, all of which I've read. That's why my eyes are watering right now, having read all of that stuff. But it's a very small portion of Obamacare. It has to do with the creation of ombudsmen, which are representatives and advocates for patients. It's something that you need to demand. And also the need for increased health literacy. There's a program in Obamacare that deals with that, but it's a very small snippet. And you need to push to get that expanded. Now, you had a second issue.
the other thing I was just gonna say besides the billing is that people need to learn the system and to be able to ask questions. When you come in the doctor's office and somebody who's not an RN, nothing critical, does your blood sugar or your blood pressure and says, that's fine, and you should ask the doctor again. It's okay to say, you know what, I know she's not a nurse, but could you take my blood pressure again? People are walking out the door with no education on how to lower their blood pressure.
That's where the
It's
health
way out
literacy comes
of
in.
whack.
That's part of health literacy. It's not just a matter of understanding what these difficult terms are that we as doctors use. It's a matter of understanding what medical care is all about. And doctors don't have enough time to explain every single thing to patients. There has to be some mechanism developed in those offices or outside of the offices where people get that kind of education.
Dr. Williams, one thing that we see in Fresno, that we have seen in our personal lives is that it's such a joy to see people come in who have struggled with not having insurance for ages, and then they finally are able to get insurance because of the Affordable Care Act, only to find out that the insurance that they have selected under California, they can't find physicians in Fresno County who will accept them as patients. And it's tragic. You know, like Denard signed up for Blue Shield under the ACA. He's a community hospital physician. Community hospital does not take Blue Shield. Why? Because Blue Shield negotiated a rate that was so low that would be almost impossible to cover the actual cost of the patient's visit. So, I mean, you know, his practice is his ministry, and people know that. So he's going to accept people no matter what. But, you know, what do you do? And then you have doctors that are participants in the ACA that don't want to take ACA patients. And then you have other physicians, primarily minority physicians, that want to sign up for the Affordable Care Act that are being denied the opportunity to sign up. These are the people that will actually see patients who have Obamacare.
Let me explain something to everybody, and I want you to listen to this. There is never going to be a time when the insurance companies are going to allow themselves to be put into a position where they're on the losing end. They are going to always create some kind of mechanism that will allow them to emerge on top. What you were just talking about, Pam, is something that we call in the business risk adjustment. Risk adjustment is a very complex, but also a very simple mechanism which allows the insurance companies to adjust the networks, their networks, for their benefit. In other words, if it looks like the patients that are coming to them are too costly, that they're having put out too much money, they are allowed to make an adjustment, you know, in regards to how they see these patients who, or how the patients are allowed to be seen in pain. So that's one of those sneaky things, but completely legitimate things that are occurring. And what you described is absolutely accurate. The question is, what are you going to do about it? The only way I see anything to be done about it is, again, to do it through congressional action. And that congressional action actually starts in your state government. You can start with the state, and you've got some wonderful, marvelous people in state government.
ACA is controlled by Jerry Brown.
There you go.
And so the issues with ACA needs to be started in California.
That's right.
And, you know, some of you know that I did try to keep up with it for a while. We have deserts. We have medical deserts. There are no black doctors. We don't have enough primary care black doctors, number one. But the insurance companies don't want a lot of sick people. The thing that got me interested in the first place was the Affordable Care Act was being set up in California by the people who set up Cover California, and they were doing it to avoid sick people because they said they couldn't make it work if they took in a lot of sick people. So it started out with a bias plan, and that bias has run through it. And the insurance companies, I was going to suggest that we might want to talk to our insurance commissioner. I don't believe there's nothing we can't do. I mean, I don't. We all know, but forgive me, you see me wearing my Hillary pen, so I'm going to do my partisan number. All know that since we had the Affordable Care Act, it could have been repaired in many, many ways over the years. Congress did nothing because they wanted to kill it. The Republicans in charge, they want to kill it. They don't want this to be President Obama's legacy. And so instead of doing what most programs would do that's massive like this, the Congress picks up this, and then they fix up this, and they fix it up, and they fix it up until it's working well, they just let it hang out there, hoping that eventually it will go away. It cannot go away. We are responsible to make sure that it doesn't go away. I do disagree with the doctor on one thing. I think if Hillary comes in, that Obamacare is going to be not only made better, but it definitely will survive.
No, that's not what I was implying.
Oh.
That it was I would never repeat the question.
I'm a DNC member.
Let me clarify something. It does not all depend on what President Obama thinks or does, and it will not depend completely on what Hillary Clinton wants to try to do. What it's going to depend on is something that you also need to keep your eye on. Who's going to be that ninth justice on the Supreme Court? You see? It's all stacked up right now against Obamacare. You have to make sure that you keep your eye on the sparrow, that you make sure that you don't let us get caught in a trap where we get somebody like, what's the gentleman's name who passed? Scalia.
Yeah.
Back in there, so that you got this conservative 5-4 majority on the board. Because that's where your big decisions are going to be made in regards to the survivability of Obamacare. There have already been 3 huge attempts to eliminate it altogether, which were rebuffed. You never know whether that's going to be able to be continued. So I'm not saying anything against Hillary. I'm just talking about what might happen with the next administration, with the next appointment of the Supreme Court Justice, etc. That's all very important. And also, the next Congress. And all that stuff's going to go back. Yes, ma'am.
You made a good point about state legislators voting, and you also talked about insurance companies do not want you to be sick. But there was a good article in Newsweek magazine about seniors are the ones who vote, and in many instances, we are the ones who are sick. We need to vote. We need to tell our grandkids, and people to vote, and we can change some of these things. Because I believe that all politics is local. We need to do what we need to do so that we can be healthy, especially health-wise.
She is.
That's wonderful. That's exactly what you need.
Well, everybody knows what we need to do in November.
Yes.
And then I think a lot of the other things you're talking about will fall in place if we do right in November. So
May I mention one other thing that you need to know about? Now, we talked about drug pricing, and we talked about pharmaceutical companies. I'm firmly in favor of what it says here about no on Prop 61, and I want you all to know why. It's because what I said about the importance of pharmaceutical companies. Don't try to make it seem like pharmaceutical companies are the devil in this situation. They are not. They are actually wonderful organizations. We spend a lot of money trying to bring the drugs to market that you need to get well. But there's something that is happening that you need to know about. It's called adverse tiering. That's a strange term, but it has to do with the fact that some companies will create put drugs on tiers, on the highest tier, so that it makes it impossible for the average patient to get these drugs, and therefore they don't get good treatment. The worst example, or the best example, is patients who have HIV. They need these very expensive drugs. The companies that make them have put these drugs on in an adverse tiering category. So that makes it extremely difficult for HIV patients to get the medication that they need to save their lives. And this is something that you need to oppose, you need to be aware of. Again, that doesn't mean that all companies are bad. It means that we got to watch out for those which are. Thank you.